Okay.
Okay, friends, we are live and Aarti madam, you can start.
Right. So, very good evening, my dear colleagues. I hope all of you all have comfortably settled down, because now from this masterclass on management of bowel injuries in gynecology, you're going to walk away armed with a new set of skills and knowledge that are going to make your surgeries much, much safer than what it used to be. Now, if you're thinking who does master classes at 9, I can tell you the one of the few people who does master classes at 9 is Dr. Jay Mehta. He's very unconventional in many ways. Jay, I know you don't like long introductions, but I'm going to take a minute to tell people out here how unconventional you are. An unconventional surgeon who enjoys doing and going where most of us fear to go, somebody who has the guts to do live surgeries, the most difficult surgeries, an unconventional teacher who not only imparts knowledge, but ignites a spark of curiosity among his fellow colleagues, someone who immensely respects his teachers. And I must warn you that assisting him is not for the weak-hearted, because it's like having an adrenaline rush. But the problem is you are having the rush and not him. He's so cool as a cucumber. He's very down to earth and he speaks excellent Malayalam. That's just a little bit about Jay. Whatever I know of him in the last few months, highly unconventional. So get ready to expand your perspectives with this masterclass, and kudos to all of you all for taking the time to be here at 9 p.m. in the night and embracing the unconventional. So over to you, Jay. Dr. Kiran and me, discussed and thought that we will divide this whole segment of discussion of management of bowel injuries in gynecology into 3 segments, where we'll initially start asking you questions about, before we go ahead and start the surgery, what we need to be aware of, during surgery, what we need to be aware of, and then post-operatively, what we need to be aware of. So that's how we're going to take you through this whole session. So Jay, before we start, I want to ask you, why did you want to discuss this topic?
Thank you. I mean, Aarti madam, I really love you. I really love your family, and you already know that. So, see, why this topic? So I'll just tell you, in a normal circumstance, no, this is something which we fear. Okay, what is it? See, there is a beautiful fear factor is something which is very powerful. If I scare you, if I tell you that, Aarti madam, I have got a machine which does not cause lateral thermal damage, buy it. Understanding, you will buy it because you are worried. You are worried that that lateral thermal damage is going to risk injury to the ureter, bowel, whatever. Okay, and that injury is going to screw up your career, because no matter what you say, no matter how we try to behave, we all know that when we have this injury, okay, we panic. Okay, see, we don't panic when we do a vaginal delivery, correct? In vaginal delivery, we go down, there is 200 ml blood coming from the placenta. We give an episiotomy, I think, right? People still give episiotomies, no? So people give episiotomy and the baby comes out, and then the placenta comes out, and everything is messy. In that situation, we are not scared. We are not scared because we are doing it from the first day of gynecology. Okay, but what is the problem in the bowel is that from the first day of gynecology, you are told that don't go close to the bowel, don't touch the bowel, pack the bowel, push it in the upper abdomen, push it in the lower abdomen, whatever. Use that mop, wet mop on the bowel, only wet mop on the bowel, no dry mop on the bowel. So all these type of things, they get imbibed in everybody's head. Okay, and because they get imbibed in your head, people get scared. And I think partly, sometimes people also get scared because they have never seen their bosses confident about it. See, for example, if I saw when I was doing PG, I saw that my boss was doing only radical hysterectomies. Okay, so he would do the dissection, he would finish off lymphadenectomy, and then he would say, okay, yeah, now you do hysterectomy. Understanding? So hysterectomy was made a very small part of the game from the first day of post graduation, which is why when we were with Dr. Ashwath or Dr. Sarina, we used to say that saw so other peripheral things that we thought that not, but this scares normal people. When you try to say that, array, what will happen if the bowel gets injured? What will happen if there is a rectovaginal fistula? How will I identify? So probably due to that, and see, one day or the other, if you are operating, this is going to happen to you. You can't really have a career without a bowel injury as a gynecologist. It is not possible. Okay. And I think that is why this topic is important, because people should understand when you have a bowel injury, what you should do on table. Because at that point in time, you can't call people. If you call a general surgeon, if you call a colorectal surgeon, if you call a urologist, gynecologist, everybody will take at least 15-20 minutes to come. And in that 15 to 20, even if they are in your hospital, okay, even if they are operating in the OT besides you, they will take 15 minutes to come. So for those 15 minutes, for those initial time, what you are supposed to do, and post-op. See, people go on that, fasting spree, 5 day, no food, no water, no milk, nothing. Okay. That actually causes a lot of paralytic ileus and electrolyte imbalances, right? But we are taught that way. So hopefully with this session, we'll give some routine concepts. These are not high fundu concepts. These are routine things which we've seen our friends only do. Okay. And we can extrapolate, and hopefully we should not be scared the next time we have a bowel injury. Of course, we should not do it. Okay.
Right.
Nobody wants
Prevention
to injure.
is better than cure.
Yeah. But if in case we do injure it, then how do we manage it is important, right?
Right. What are the risk factors, Jeff? I mean, for bowel injury, what should we be aware of before operating, a patient? What are the risk factors?
See, honestly, you will not believe the cases which are the simplest, no, are the cases where you might have a bowel injury. Okay. For example, the simplest case to have a bowel injury is when non-scarred abdomen, virgin abdomen, and when you are putting a trocar. Okay, many times it will happen. Many times it will happen. Your trocar might go slightly deep. Patient is obese. You don't know if it has touched the bowel. If it has touched, you don't know if it has nicked. All these things. So right from the word go, it can happen. Second thing, a lot of times people say, I like to do MRI, I like to do ultrasound, I like to investigate thoroughly. All that is good. But all that is not going to prevent injury, because MRI reporting may or may not match with surgical pictures. We all know that, right? Unless and until you are reading the MRI on your own. And then they need to understand the concept of the disease, of course. See, if you understand the concept of any disease or any adhesion for that matter, it's not common to have a bowel injury. But having said all these things, I also want to say that I have had bowel injuries. There is no denying that fact. I have had a bowel injury in one of the simplest of the cases, which actually ended up in court, and I won the court case. But it was the simplest of the cases. Where it was a trocar injury on the ileum and on the small bowel, and she ended up with fecal peritonitis. In 24 hours, we diagnosed fecal peritonitis. We took her up in the OT within 20 hours of the primary injury. We did everything correctly, and what happened is, at the end of it, she did not come out of anesthesia. So she was kept on ventilator for 14 days. Okay. That was because of her pre-morbid conditions. She was diabetic, she was hypertensive, and all these things. She went back home. After that. But then circumstances were such, and our colleagues were such, that they were instigated, and they were like, you go to court, you will get 20, 40, 50 lakh rupees. We'll suspend his license, this, that. Nothing happened. Okay. Nothing really happened. So one more point I want to drive here is, if you have done everything right, the court is not there to crucify you in a bowel injury. Okay. If you have done everything right, what is doing something right? Identifying the injury is the right thing to do. Treating the injury is the right thing to do. If the injury which you have treated has not leaked, that is the right thing to do. Understanding? And if you have done everything right, listen, if a general surgeon cuts open a bowel and there is a leak, he is also liable to go to court. Understanding? It is not that a gynecologist is liable. Any doctor is liable to go to court. Okay. The court does not really tell you all these things. So that fear is in our head. Array, patient will go to court. Array, there is going to be fecal peritonitis. Array, what is going to happen? Array, what is going to happen? Something like that. And I think that if we train ourselves, we'll overcome that.
Right. So that is a great take-home point, that even virgin abdomens can give you issues like bowel injury. But then that said, of course, patients who have endometriosis and those with previous surgeries are the ones who are at higher risk of, having these sort of issues.
Absolutely. See, that all we know, that if there is a scarred abdomen, right? If there is a previous midline vertical incision, we know that some bowel might have got stuck there. So we are going to avoid all those by, taking Palmer's point, this, that.
Right.
But that does not mean that in a simple, straightforward case, you can't have an injury. In fact, you would not believe majority of the fecal peritonitis whom we see is in simple cases.
Okay.
It is not in tough cases. It is in simple cases.
And how do you prepare the bowel before these surgeries, Jay? What is the importance of bowel preparation before?
See, if you actually study, I'll just explain a concept here. See, what is bowel preparation? Bowel preparation is something which keeps the bowel empty. Correct? That is it. Now, let's assume if you ask a colorectal surgeon when they are doing colorectal surgery, let's say when somebody is doing a hemicolectomy. Okay. So I'm called in as a ghost surgeon by many people to do hemicolectomies. Okay. So what do they do in a hemicolectomy? What is that concept? Why do we want a bowel to be empty? And which part of the bowel do we want to be empty? These two are very important things. So if you ask a bariatric surgeon, he is going to tell you that upper GI tract should be empty. Understanding? Stomach should be empty. There is a gastroduodenal junction, which is a strong valve. Okay. So duodenum will keep on secreting bile. Duodenum will keep on secreting pancreatic juices, but they will not come up. They will not come to the stomach because of that valve. So a bariatric surgeon wants the stomach and esophagus to be empty, right? If you ask hepatopancreatobiliary surgeon, he is going to tell you, "Arey, whatever I do, there is going to be some bile and some pancreatic fluid which will leak out. So it's okay with me. I don't really like to give heavy bowel preparation. I am okay with the stomach being collapsed with a Ryle's tube." He's happy because Ryle's tube is there till the end. First part of duodenum, his Ryle's tube is reaching. So he's happy in that. Okay. If you ask somebody who is operating below, if you ask somebody who is doing let's say superior mesenteric artery syndrome, he is going to tell you, no, nothing happens here. The bowel is necrosed. I will operate on a necrosed bowel. If you ask a oncosurgeon who is operating on malignancy of the large bowel, he'll tell you, even if I want the bowel to be empty, it is going to be such that there is a constricting ring, so the stool may not pass out. Understanding? And if you ask a gynecologist will tell you, I want empty bowel for diagnostic histolaparoscopy. Right? So everybody has their own criteria. So if you ask our colorectal friends from whom we have learned a lot, and I work very closely. I have worked very closely in my early days with one Dr. Rasik Patel. He is a general surgeon. He is in Bombay. He is very well known and he's a very dear friend of mine. So, he always had wonderful concepts of colorectal surgery. So colorectal surgeons will tell you, even if the bowel is not empty, it is okay. But when they want to anastomose it, do you know what they do? They flush out the stools, right? So they make the bowel empty manually. If you ask a colonoscopist who is a gastroenterologist, he'll tell you, I want an empty bowel because I want to pick up those small lesions. I don't want stool staining on the mucosa. Right? So if you extrapolate all these, we have somebody very nice. Sorry to interrupt, but we have somebody very nice. Yogesh Shirgupe is a fantastic endoscopic surgeon. He is joined. I would wish to unmute him because he's too good a guy. And if he doesn't mind, I'll at least request him to unmute. Yogesh bhai, I have requested you. Your inputs will be valuable. Okay. So see, if you look at gynecological surgeries, where are we operating? We are operating in sigmoid. We are operating in descending colon. We are operating in the rectum. Okay. So we are operating in some of those high pressure zones, right? We want an empty bowel because we know that if this bowel cracks open, just note this point down. If this bowel cracks open and if you missed an injury, okay, the peritonitis is severe because the amount of bacterial load which comes out of this is huge. Okay. Second, because it is a high pressure zone, even a small rent will cause a big leak. Okay. And third, even if it is a small rent, the rent will get edematous within 6 to 8 hours of the injury. All right. Which is why we want an empty bowel. which is why when we see fecal peritonitis from gynecologist, which has been a rectal injury, so God has one mechanism to correct it, which is to create a rectovaginal fistula. Okay, that is God's mechanism of correcting it. God will say, you can't do much, I'll knock out the vagina and the stool will go out from there. But sometimes God is also sleeping. Okay, in that situations, what is going to happen is patient will end up with fecal peritonitis. And believe me, fecal peritonitis is deadly. So what do you do in fecal peritonitis? We have shown it live on Facebook, right? We do a Hartmann procedure. If it is lower rectum, do a Hartmann. Okay, don't end up doing ileostomy. Ileostomy to be done as a covering ileostomy to repair the primary injury. If your primary injury is not repairable, just do a Hartmann and leave it. After 6 months, after 3 months, you will be able to do reanastomosis. That wound would have got fibrosed. Your cologram will show it is fibrosed. Go and suture it and put the Hartmann closure. So that is something which we do a lot for fecal peritonitis, a lot.
Jay, do you recommend a general surgeon being there during these high risk cases? Especially, with doctors who are still a little fearful and don't have that sort of fearlessness like you to deal with.
No. To be honest with you, Aarti madam, it's not that I'm fearless. Okay. Trust me. I may be very calm while doing a surgery. That is because I do so many of these surgeries. Okay. But otherwise, there is nothing that I am fearless and somebody is less fearless. Everybody is fearful in life. Okay. You may keep a general surgeon, but just keep one thing clear, that a general surgeon would have also seen it for the first or the second time. This is a point which people forget understanding. See, a general surgeon, I know so many great general surgeons who are practicing in Bombay. I know one guy who is world famous practicing in Ghatkopar. He's a hernia specialist. He's a general surgeon. He only operates hernias. If you call him for a bowel injury, he'll tell you, boss, where have you called me? Understanding? Because for the last 10 years, he has not probably gone, to repair the bowel. So you want to call somebody, you call somebody who will actually do that thing for you. Because at that point in time, what you do is more important than what your degree is.
Right.
Okay. This is what I strongly want to convey. You can call general surgeon, no problem. Call urologist. Urologists are so good at handling the bowel. They do so many radical cystectomies with ileal conduits. They handle the bowel as well as a general surgeon. So there is nothing which states that only call a general surgeon. So by that logic, the court is going to ask you, why did you not call a colorectal surgeon?
Right.
You damaged the rectum. Call a colorectal surgeon, right? Listen, I personally think these type of things should not be incorporated. Yes, if you have a team, inform them, keep them on standby so that they give you the time if you require any such help and if you want something like this. But otherwise, I guess we've been doing all sorts of surgeries without having anybody in the OT,
Very well taken point, Jay. A few more questions, Jay. Does a Veress needle usage instead of a direct trocar reduce the chances of an injury? What is your recommendation?
See, Veress needle and direct trocar, both are blind. Correct? Right. At the primary entry, both are blind. So Veress needle will cause a small injury, let's say 2 millimeter. Actually, the trocar tip is also 1 to 2 millimeters when it goes inside. So the dimension of injury which is caused by both is the same. Okay, it is the same. See, I had something beautiful. I had something beautiful 2 days back. Not 2 days back, I think 4 days back, before I went to Chennai. Okay, there was somebody whom we were operating with a 35 centimeter ovarian cyst. Okay, so it was a mucinous cyst adenoma. So I thought it's a mucinous cyst adenoma, I'll go little high up. Okay, in this thing of going high up, I went through and through the stomach. Okay, anterior wall of stomach, posterior wall of stomach, trocar. Fine, beautiful. I thought, sorry, I didn't know only I've gone through the stomach. Understanding? So when I was taking out the trocar, when Vismay was taking out the camera to clean the camera, then when he put it inside, we saw the stomach and we were like, Arey, after 15 minutes of surgery, why did the stomach come here? Then Normally, when we go high up, we always tell our anesthetist, sir, rice tube dal do zara. We want the stomach to be empty. This time, none of us said, because he thought Jay has not said, so no need to put, yaar. Okay. So then what do? I had a stomach injury 4 days back. What will you do? Shall I call a bariatric surgeon to come and staple it? Okay. Or shall I open the abdomen and find out where is that injury? Okay. So what did we do? We kept the trocar inside only, inside the stomach. Okay. Any which way stomach will distend beautifully. When you eat chicken tikka masala, like when you gave me that Hyderabadi biryani, stomach will distend for 1 liter. Understanding? So the gas will first go in the stomach and it will delineate the lower border. Okay, where that injury is. You can just go and take PDS, because stomach injury is something which we do very commonly when we are doing radical omentectomy. That time we don't call anybody, So we took PDS downstairs. We took the anterior border. We took one more PDS out there and we left it. No omental flap, nothing. Patient started eating food after 8 hours of surgery. She has gone home. She has not complained. See, otherwise by now she would have leaked and died. Understanding? But nothing happens. That is the thing. See, at that point in time, I can't spend that 45 minutes waiting for something like this. Rather than that, learn it. Yeah, call a guy, keep him in the OT, you repair it. Because remember one more thing, a point which people often forget. Endosuturing is critical to, treat fresh bowel injuries. Laparoscopic suturing is critical to treat fresh bowel injuries. And our general surgeon colleagues, our urology colleagues, they are fantastic endoscopic surgeons, but they are not very used to suturing. Understanding? They're not, yes, out of 100, one will be good. But the other 99 are not very used to it. Because they are not very used to it, they'll say, "Arey, open karte." The reason why they want to open is because they want to suture it nicely. The same thing, if you can accomplish laparoscopically, you are going to be in a much better state. Okay, so as a gynecologist, that is your advantage. You do so many myomas, you can suture. Same thing you can do to the bowel also. Same thing you can do to the ureter also. Same thing you can do to the diaphragm. We recently posted that paracardiac. We had opened the pericardium, yaar. We sutured the pericardium, no? Laparoscopically, we sutured the pericardium. So nothing happens. We don't need a cardiac surgeon for doing that. Yeah, if I go in the heart, by the time the cardiac surgeon comes, my heart will be in my mouth and patient will be up. Okay. So some basics we have to learn is what I really think,
How many cases, Jay, have you done where these bowel injuries were referred to you in the last year?
I mean, one a week.
Yesterday when I spoke to you, you said there was a bowel injury. You had to, fly down.
Yeah. 1 a week.
Go and operate 1 a week.
Yeah, 1 a week.
Okay, so that's
let's say 40 to 50 in a year.
Okay. So Jay, you gave us wonderful take homes that it's not only in the high risk cases but also in the virgin abdomens that you must be prepared for bowel injuries. We should not. One more important take home was, do not get worried, learn to deal with it. You don't need to have a general surgeon always in the OT, and a good bowel preparation, the science behind it, why we should have a good bowel preparation was beautifully explained by you. So over to Dr. Kiran.
Aarti madam, I think Yogesh wants to ask something. Yeah, Yogesh bhai, I saw your hand. Sorry. You can unmute yourself, Yogesh bhai.
Yeah. I just want to say one thing. When you get a fresh trocar or new trocar, it's very sharp. So while putting, you have to be careful. What I prefer, I rub it and I make it a little blunt. If it touch to the bowel, it won't perforate. But the new one, they are like needle. Immediately they will perforate. Many times you may not notice also that some 1 millimeter, 2 millimeter perforation has on.
Yeah, that's a point, but I'll add something to that. So a lot of times people will try to market something called as optical trocar to you. Okay. That is something where you put a 10 mm scope inside a trocar and you will see the trocar entering through the sheath, entering through the peritoneum. Listen, that is all that is all not very good stuff. Understanding why? Because if the bowel is stuck, it is stuck to the peritoneum. Are you understanding? It is stuck to the peritoneum. So after you pierce
Then
the
only
preperitoneal layer, you will enter straight in the bowel with that. So I've had, I'm operating something tomorrow where beautiful optical trocar was put, which has gone through the bowel. It is called the ileovesico-vaginal fistula.
oh,
Okay, ileum to bladder, bladder to vagina. Beautiful fistula it is. It's only 2 centimeters in size. Okay. So, and operated by a general surgeon. Okay. Patient has been couriered from Delhi to Bombay. I was talking to Shilpa madam about it. Okay. So, listen, uh, it's okay. People will have this injury. It's okay. If you are doing 100 cases a month, if you don't have an injury, if you have not done a complication, you are a bad surgeon. That means you are operating on 6-week, 8-week unindicated TLH. Understanding? If you have injuries, if you've gone and some TO mass has leaked, it happened with us in Chennai very recently when I was operating with PP. I'm sorry, when I was operating with Padmapriya, we had some appendicular abscess. We were told it is an appendicular abscess query TO mass. We called the general surgeon. Everybody was in the OT. None of us knew where I was operating. Understanding? The whole thing was walled off. After some stroke of luck happened, and we dissected everything, and appendix was lying in one corner. Okay. So it's okay. See, some things like this will happen. If it happens, you have to manage. If you think you cannot manage, then first you have to build up your confidence to manage and then touch these cases. If you don't build up your confidence and just go on touching cases, then you will lose your confidence. And I think that is very, very important take home point.
Right. Jed,
Yeah.
many of our colleagues are asking, what is your way to prepare the bowel? What is your take on?
Yeah, so sorry, we were mentioning that. So I'll tell you what is my way of bowel preparation. I give Exelite, okay, either 45 ml or 90 ml in 300 ml of Sprite, which is to be given approximately 8 to 10 hours prior to doing surgery. Okay, now let's assume you have an emergency situation and you want to do a basic TLH and the patient has got admitted in the morning. In that situation, you just need area from below the sigmoid to be empty. So you just need sigmoid and rectum to be empty. Like how we do it in delivery. Why do we want that rectum to be empty? So that, there is no vaginal fistula on a loaded bowel. So what do? We give enema in that situation. In an urgent situation, you can give enema with an Ayurvedic preparation called Gasex or Dulcolax. Gasex is a good tablet. It causes the bowel to collapse down little. And in these situations, you should use spinal plus GA because spinal will cause more amount of small bowel collapse. And when you have a good small bowel collapse, you will get space inside the abdomen. But this is in emergency situations. Okay.
Right.
So we'll answer all questions for people in the ending. You can keep your hands down. We'll answer questions. Don't worry.
Over to Dr. K.
Thank you, Jay. That was fantastic till now, and I acknowledge the presence of Dr. Suchita Bachcha. She is a very senior gynecologist from Nagpur, from Nasik, and welcome, ma'am, on this forum.
I know madam very well. Hi, Suchita madam. Yeah.
So Dr. Aarti had covered the pre-op issues. Now coming to the intra-op issues, you very clearly mentioned that the optical trocar is of no use at all. Now, in case you are using a Veress needle, and in case the Veress needle goes into the bowel, first is how to identify whether the Veress needle is in the bowel, whether by saline test and aspiration that is good enough, or by the smell, or by anything else. Yeah.
No. See, two or three concepts actually people don't know here. When you put a Veress needle and it's stuck in the muscularis, that is the only place where your saline test will fail. If your Veress needle is inside the lumen of the bowel will distend beautifully, man. Your saline test will go, you insufflate, intestine will dilate nicely, nothing will happen. And you know where it will distend? It will distend in the ileocecal valve because that is the only thing which will stop further gas from going inside. Understanding? If you've gone in the large bowel, you will see flatus coming out from the rectum with your insufflation. Okay, so people should know that. People have this wrong concept that when you are doing saline test on that Veress needle and you aspirate and the needle comes back, all that is okay, very good. That is good to pass your exams, understanding. But in real life situation, Where the varus needle is important. Is the needle in the muscularis? Then nothing will happen. Then you will feel that it is, it has gone in, water will not come, saline will not come out, gas will go down, everything will happen. You will come to know only if you have entered inside the abdomen. See, one more problem with varus needle. Okay, when you then on the gas, when you start the insufflation after varus needle, the problem is there will be some distension. Okay, there will be some distension, but by the time you take out the varus needle, okay, you will lose track of where that hole was. Okay, and that is something which causes the maximum amount of fecal peritonitis which I see.
Okay. Okay, so in case, so the next issue is, in case you have injured by the varus, should it be repaired or should we just leave it? Will it heal it on its own?
Oh, every bowel injury, it is to be repaired.
Okay.
Okay, see, remember, once you damage the serosa, okay, then there is circularis muscle. After circularis muscle, what do you have? You have the lamina propria and then you have the mucosa. Okay, this is the anatomy of any bowel. So after that circularis muscle, there is nothing to give strength to the bowel. And bowel has peristalsis. So what does peristalsis do? It's like a cylinder. One part will constrict, the other part will expand. The minute your circularis is damaged, the part will expand, which will blast open in the peritoneum. Understanding? Because for that, it is the easiest exit point. So if you have damaged serosa and you've denuded the muscularis, okay, kindly go and suture it. There is nothing which tells you that don't suture it. You must suture it.
Okay, fine. Now, how will you identify the injuries by trocar?
Oh, you will know. I mean, trust me. You will, when it has gone, no. See, when you over experience, when you are putting a direct trocar, no, if it has touched something, no, you will know it has touched something. Believe me. I mean, that is your gut feeling. Arey yaar, kuch to maine touch kiya hai. You know, you will have that feeling. Believe me.
Okay.
But let's assume you don't get that feeling. Okay. Let's assume you did not get that feeling. Then usually you will see a small hematoma which has started to develop at the part of the omentum or the bowel. Okay, you will see that hematoma because that hematoma will form immediately. Okay, and you will see that. It is very rare to not see a hematoma.
Okay. What we are normally told is you put in a scope and rotate the scope by 360 degrees. If the scope is to the bowel, then obviously you will come to know.
How, but that is before giving head low. That is before you give head low. Only then it is of advantage. Okay. Normally in practical life situations, what happens is the minute you put even before you on the light, I mean, even before the camera goes inside, our assistant will start the insufflation. Understanding, and anesthetist will give head low, thinking that isko head low lagne hi wala hai. Okay, in that type of situations, this protocol does not work.
Okay.
Remember one more thing. You have to be very bad. I mean, it has to be a very unfortunate thing if the injury has occurred to any bowel which has a mesentery. Okay, because that is a mobile bowel. So injury to the stomach is very good, no mesentery. Injury to duodenum is very good, no mesentery. Injury to jejunum and ileum is bad. It has mesentery, difficult to locate it. It will wobble. You will not know where that injury was. Injury to appendix, very good. Injury to ascending colon, very good. Injury to transverse colon, very bad. Because transverse colon is very big. So people will miss out on where that injury was. Injury to descending colon, very good. Injury to sigmoid, very bad. Because again, sigmoid injuries, because of the mesentery, it will keep on wobbling and it will spill across inside the peritoneum. So anything which is retroperitoneum, and if you have injured a retroperitoneal bowel, you should be happy. Injury will not move. You will be able to locate the injury and you will be able to suture it faster. Any mesenteric injury, I mean, any injury over a mesenteric bowel, it is difficult to suture. So just keep that in mind. You have to stabilize it first, which is why you have bowel clamps to stabilize the mesentery. Okay. The reason why bowel clamps were introduced in science was to stabilize the bowel. You need stability when it is wobbling. You don't use bowel clamps over sigmoid. You never do that. You use bowel clamps over transverse colon. You use bowel clamps over ileum, jejunum, whatever. Okay. So just keep that concept in head.
Great. Okay. Now coming to the next question is ischemic injury more dangerous than the diathermy injuries?
See, ischemic injury, you have to be a really good guy to cause an ischemic injury. That means you have to go to the source of the vessel and coagulate it and then cut it. Understanding? That will cause an ischemic injury to a large segment of the bowel. Okay. Otherwise, the ischemic injuries which occur to any other part of the bowel is not because of actual ischemia. It is due to strangulation. Understanding? And that strangulation can happen due to a lot of things. Adenomyoma bed giving way in gynecology. Okay. Fibroid bed giving way. There was an intestinal band which you failed to release. There was a mesh which you kept, but you did not do extraperitonealization of the mesh, which causes the bowel to go inside the mesh and cause strangulation at focal points. Okay, all these things are common causes of having strangulated ischemic injuries. In that, it is very simple. It is always the small bowel which will undergo strangulation, because small bowel is the part which wanders around. Okay, and signs and symptoms are very fast. You have paralytic ileus and vomiting, very fast with tachycardia. So usually it is small bowel only. Okay, in these type of situations, and you need resection anastomosis. You can do it laparoscopically, no problem. If you have large bowel ischemia, that is predominantly if you have cut a vessel. Yeah. If you have cut a big vessel, if somebody goes and cuts the inferior mesenteric artery, okay, if you do something like that, then you will have ischemia. You will require covering colostomy in that situation. But that is rare, sir. We don't see ischemic injuries in gynecology apart from small bowel. Small bowel injuries is strangulation. The problem with thermal injuries is much more common in gynecology. Okay, much more. The most common injury to large bowel in gynecology is a thermal injury. And our thermal injuries are real beautiful, proper, pakka thermal injuries. Okay, we coagulate the serosa first, then we cut. We coagulate the circularis, we cut. We did not realize it is muscularis and mucosa. We coagulate that and we cut. And then we realize the haila. ये सब मैंने coagulate किया है. Let's assume we did not realize it. We'll coagulate it still. And we'll coagulate it with all our pressure on that bipolar. जोर से pedal दबा, जोर से दबा के रखो tissue को बीच में. So you have beautiful coagulative injuries, thermal injuries in gynecology. None of us use monopolar anymore. Otherwise, monopolar is super safe on the bowel. It will cut the smallest possible part, on the bowel. Monopolar injuries are much more safer than bipolar injuries on the bowel. Bipolar injuries will really cause beautiful necrosis and big rent. Bipolar injury means big rent. 1 centimeter and above means bipolar use kiya hai, something like that.
Now coming to these thermal injuries, when you try to repair these injuries, do you just refresh the edges or you do a resection anastomosis? See, normally it is very rare that somebody has done a thermal injury and has realized it on the spot. The maximum amount of videos which people send me when they are operating, okay, the commonest call, which in fact we get 2 times in a day, is that an instrument has touched serosa and has caused blanching of that bowel. Just touched kiya and that part has caused blanching. Now shall I take silk sutures over it or not? Or now shall I take barb suture over it or not? Okay. See, remember, if it is just a serosal injury, which is the 90% of the time, okay, nothing needs to be done over a serosal injury. You don't need to put that saline, cold saline, warm saline, cold saline, warm saline. Kuch karne ka zarurat nahi hai. You don't need to put Intercede over it. You don't need to do it. If it is just then touch kiya se, then you have to be worried. But touch kiya bipolar se, nothing really happens. Okay, because if you touch with the monopolar, the injury is deeper because the current is monopolar current, so it will go deeper. Understanding? But otherwise, with bipolar current, if there is a touch injury, you don't have to do anything. Just observe. Okay, observe means don't put a drain and all these things. Keep the patient okay and active. No need to worry about that. Where does the main problem come? Problem comes in if you have coagulated and you have left a large segment like that. Then over a period of time, it will undergo necrosis
and it will come to you as a big fecal peritonitis with a huge amount of inflammation. Okay, so that is a worrisome aspect.
Yeah. So the question was, if at all you diagnose it intra-op, or even if the patient comes later, do you just refresh the edges and do suturing, or you do a resection?
No, it will need resection anastomosis.
Great. That is the biggest thing that I wanted to know from you, because we have had a case about 15 years back.
Yeah.
20 years back, when very senior eminent surgeons were called, and what was done was just refreshing the edges. And what happened was that after the edges were refreshed, even they didn't know how to do it. So the edges were refreshed, the bowel was sutured, and again this patient landed up into a secondary fecal fistula. So at that the resection anastomosis. So this is the most important take-home message. Thank you for that. That in case of a thermal injury, it is better to do a resection anastomosis at least 2 centimeters on each side, and then you suture the bowel. Okay, fine. Coming to the another thing that was that came to my mind was, often we are taught that small bowel injuries usually reveal on day 4, 5, 6, and large bowel on day 7, 8, 9. So that's another thing that was taught to us by many of the surgeons. So yeah. So coming to the next question is size of the injury and decision to suture. If the injury is less than 2 centimeters, how will you suture? If the injury is more than 2 centimeters, how do you suture? Or is 2 centimeters as a cutoff? Is it a cutoff limit?
Okay. See, I'll answer this in a simple manner. Don't go by the centimeter definition of injuries. Okay. Just remember one rule. Whatever you do, you suture perpendicular to your line of injury. Okay. Whatever you do, you suture perpendicular to the line of injury. Don't go by 2 centimeters, 1 centimeter. I'll tell you the reason for that. 2 centimeters of a collapsed bowel and 2 centimeters of a distended bowel is completely different. 2 centimeters on a distended bowel, you can easily suture, nothing will happen. 2 centimeters on a collapsed bowel is virtually 70% of the circumference of that collapsed bowel. Okay. So don't go by 1 centimeter, 2 centimeters. If you have a tear, okay, if you created an injury, if you have a tear, suture, please suture perpendicular to your line of injury. If your tear is like this, you suture like this, perpendicular to it. Don't go by longitudinal suturing, transverse suturing, longitudinal suturing, transverse suturing. Don't go by that logic. Just suture perpendicular to your line of injury and you will be fine.
Great. Any steps to prevent and reduce the risk of leakage?
Reduce the risk of what, sir?
Of leakage.
See, anything which leaks, it leaks because it is in tension. Okay. So the biggest take-home point of repairing a bowel injury or repairing any injury is to keep the injury tension-free. Keep that repaired part free of tension. Keep that repaired part free of distension. Both the things. Distension is also tension. Distension is intraluminal tension. Understanding? So if you are able to prevent distension, that means if you are able to prevent paralytic ileus, 80% of your job is done. See, remember when we tell that bowel requires rest. Remember, bowel never rests. A bowel which is resting is in paralytic ileus. Okay, you don't want the bowel to rest. The bowel should have peristalsis. All your life, you are looking for bowel sounds. What is bowel sounds? Bowel sounds is peristalsis. When you have peristalsis, the bowel is not resting. Okay, please remember that point. So what people do by keeping that patient NBM for 5 days, 10 days, 20 days, whatever you want to keep. Okay, what you are going to do? You are going to cause a severe amount of electrolyte imbalance. And this electrolyte imbalance itself causes distension. Okay, it itself causes distension. It has to be avoided. Patient's bowel motility should start as fast as you can. Okay, it has to be avoided. You must start the motility of the bowel as fast as you can should you want the patient to lead a very happy life.
Okay. 2 more questions come to my mind. One is, you use routine silk for the suturing or any other material?
I use Stratafix now. I've stopped using silk.
Okay. And what is the fund of giving ice creams immediately post-op to prevent paralytic ileus? That is your popular diet post-op.
No, it is not just ice creams. See, I like to give ice creams because that is the only good thing in my hospital. I mean, people really like it. कि अरे bowel का surgery किया और doctor ने ice cream भी दिया. What a great doctor. Something like that. But you can give anything, yeah. You can give sweet corns, you can give rice, you can give dal khichdi, anything which has a high glycemic index, basically. Okay, anything which has a high glycemic index is good because usually the surgical stress which a patient undergoes causes the patient to become very hypoglycemic. Okay, and you don't want this type of hypoglycemia in the patient. Okay, so that's why we give the ice cream. Plus, ice cream is a good stimulant to the intestine. It allows the intestinal motility to occur very nicely. And because the intestinal motility occurs very nicely, the bowel stays quiet, okay, without distension. And with the bowel staying without distension, the healing is much better. Patient recovers very fast.
Okay. Yeah. The final question from my side is, what is the abdomen compartment syndrome?
Abdomen compartment syndrome for what?
Post-bowel injury.
No, I mean, see, we can probably try to, we can try to divide abdominal compartment syndrome into 2-3 parts. Okay. The most common reason why you have abdominal compartment syndrome is not due to a primary bowel injury. Okay. You predominantly see it in cases of peritonitis. Okay. And what does it normally do? What is the commonest symptom which you see in abdominal compartment syndrome is that the patient has, difficulty in breathing because of bowel distension. Commonly seen. What is the treatment? The best treatment, first put a Rice tube. That is the first treatment for abdominal compartment syndrome. And second, treat the focus. So how do you treat the focus? If you have identified the injury, immediately go inside, repair that, and then your abdominal compartment syndrome will get relieved in the next 72 hours.
Okay. I think that's all from my side. Dr. Aarti, over to you again.
Yeah, wait, I'll unmute you. Wait. Sorry. Yeah.
Thanks, Jay. They were amazing insights you gave all of us. Just in continuation with what Dr. Kiran was saying, would you want to summarize 5 important take-home messages of how to manage and prevent bowel injuries intra-op? 5 take-home messages and common mistakes gynecologists often make.
Dissect more and cut less. Okay, that is the first thing. Okay. See, always, if your principles of dissection are good, you will identify the right plane of dissection. Okay. If you identify the right plane of dissection, your injury is going to be less any which ways. You have to make an effort to create an injury, understanding if you are dissecting correctly. So please dissect nicely. What all of us usually do is we dissect little, okay, and we leave the rest to dynogest. कि हाँ नहीं थोड़ा ही करता हूँ, बहुत ही डीप है, अरे नहीं अरे नो अरे टू डीप, अरे नहीं थोड़ा बावल राइट में ले, थोड़ा बावल लेफ्ट में ले. Okay, that is one thing. So keep that sort of mental block aside. Dissect more. Okay, the entire pelvis officially belongs to a gynecologist legally, court of law, till perineum. You can touch everything, cut everything, join everything, destroy everything. Everything belongs to the gynecologist. No problem. Okay, that is the first point. Second point, kindly don't keep people NBM for a prolonged period of time. There is no indication in the world to keep people NBM. Okay, I'll tell you a joke. Okay, this is a joke, but it's a fact. Huh? Do you know how soon after bariatric surgery patient is given food? Has anybody seen bariatric surgery happening? Somebody's husband must be a bariatric surgeon, brother must be a bariatric surgeon. Do you know how soon after bariatric surgery do they give food?
8 hours.
What have you cut? Stomach. जहाँ पे food सबसे पहला जाएगा. Correct, no? What have we cut? Stomach. Correct. Food is started within 6 hours. Food is started within 6 to 8 hours. There are some good people who will start it in 4 hours also. Okay, ले पी बिंदास, lemon juice पी. You know, कुछ नहीं होता है. It is just in our head that we are fixed.
Can't hear you.
You are muted. Yeah.
Yeah.
Sorry. Audible? Sorry.
Yeah.
Yeah. In our head, that if I touch the patient cannot touch food for the next 48 hours. Keep that concept away. Come on, Aarti madam. We operated 13 people with that bowel endometriosis at your place. Everybody was eating food, no? Next day. They all went home also. They all didn't come back also. So the reason why they didn't come back is either they are dead or they are alive or they are happy. Correct? And I presume all of them are alive and happy. Correct? So there is no such thing. Understanding? There is no such thing. Right? The third most common mistake we make is we try to put our problem on others. Arey, my trocar was bad. Arey, there was a midline vertical injury, so incision, so I had a bowel injury. Arey, the whole bowel was stuck there. That is why I had an injury. Head low was not correct by anesthetist. To repair the bowel, you don't need head low. You need the anesthetist to keep the patient in supine position. That is how bowel injuries are repaired any which ways. Okay. Then we make, all silly excuses. Arey, ultrasound mein pehle pata nahi chala. Look, all such surprises are going to happen on table, which is why the patient is paying you money to handle on table surprises. If it was so prefixed, some robot will just program and do it for you. Yeah. Okay. The surgeon is paid money to handle an on table surprise. On table kya hoega na, ye tum mere ko batao. Correct. So don't get that concept. Keep that mind free. Right. Fourth thing, heaven's sake, document it. If you have an injury, let's say if you have created an injury, taken silk sutures, document it. There is no problem in giving that video to the patient. There is no problem. See, in my initial days, people used to say, you go to Jai, fistula will happen. Correct? When I was repairing fistulas, people used to make that thing. You go to him, fistula will happen. Okay. Come on. You are supposed to document it, yaar. Document it, give it to the patient. Tell them. Go out and tell them. The court case where I got saved was because I had told the patient that I think that there is something, I might have touched something, but I was not sure. I examined, but I couldn't find. I told the patient. Okay. They still went to the court. That he had told, so why he did not repair immediately. Okay. I was honest enough to tell them. I showed the whole video in the court. Okay. 2 expert witnesses. They don't even know the spelling of laparoscopy. Okay. Were called to judge that how you think it has been operated correctly. They could not find anything. They don't know only anything what they will find. Understanding? Post repair CT scan was normal. There was no leak. 3rd day CT scan, 6th day CT scan, 14th day CT scan. All CT scans were normal. No leak from the part which was repaired. Right? So you have to learn to repair and do the right thing. Okay. Commonly, people will tell you if you have a fecal peritonitis, shift to an institute. That is correct. The reason why they want to shift to an institute is because even if you repair the injury nicely, the patient will be on a ventilator. Fecal peritonitis is worst thing to handle. Even if you have handled the injury beautifully, patient will die because the load of endotoxins is so high inside these patients that you don't know. Understanding, you don't know how it will react. Right. So that is something which you have to keep in mind. And only when you document, your document will save you. Your paperwork will save you. The court, the judge, these days, judges are also very active on social media. 2-3 of them follow me on YouTube and Instagram also. So I'm very lucky that they know me, that this guy is a social media celebrity. But otherwise, what typically happens is the judge is going to ask you, Arey, when was the last time you handled this? So you are going to say, Arey, sir, I did not just handle it. I show it on Facebook Live also. Do you know? The judge will be like, kya baat kar raha hai? Seriously? See, judge is also a human being. He also has the same wife. He is also afraid of his wife. He is also afraid of his children. He also has to go up and face the same music which we have to face. Understanding? So when he is at work, he also needs some entertainment, yeah. Okay. So and usually the judges, what I have seen is, out of seeing so many judges, what I have seen is usually they don't want to pin you down, yeah. They are good. They listen to you. क्या नहीं बराबर बोल रहा है ये, इसने उसका try तो किया है, So you are going to be saved by your efforts, not by your, not taking efforts and raising your hands up. अच्छा मैं नहीं करूंगा, पेशेंट को शिफ्ट कर लो. अरे पेशेंट को तो शिफ्ट करेगा ही वो, बट वो शिफ्ट करने के पहले तुम तो कर लो, and I think that is very, very important to learn, I think.
Right. Thanks, Jay. That was very profound, your wisdom. You mentioned today in, the group that you wanted to share your experience about barbed sutures for fresh bowel injury.
Yeah, it is very good. Okay, see, normally we have this misconception that when you take barbed suture or any part in the peritoneum, okay, omentum will go and get stuck to the barb. Okay, and this omentum will then cause a serosal aspect of the small bowel to go and get stuck, and it can cause strangulation. So remember, the beauty of the barb is it really depends on which barb have you used. Okay, there is a huge difference between using Stratafix. There is a huge difference between using V-lock, and there is a huge difference between using quill. If anyone has used all the three, they are going to agree to what I'm saying. Okay, because there are certain sutures which have a high concentration of barbs. There are certain sutures which have a very low concentration of barbs. There are certain sutures which are very fine, okay, with the barb. So usually for gynecology, you should not use suture materials which have a very high concentration of barbs. For example, V-lock. It's a great suture, but it has a very dense concentration of barb. You know what is V-lock fantastic for? It is for doing myomectomy. V-lock is not very good for bowel repair. You want to repair the bowel, you use Stratafix. Understanding? It has very fine barbs. So when people often complain, I use barb and now there is an injury, I am never going to use barb again. Arey, listen, it is not that. Okay, you did not select the correct barb. You did not mention that. Okay, when you select the correct barb suture is so good, you don't have to tie a knot. Imagine. Okay, it will just suture on its own, and it is equal distribution of tension because of that barb. That allows such brilliant healing, So we must keep that in mind. We must not really abuse barb suture like that. But I'll tell you one point which I do. When I do a myomectomy, you have seen me doing that, Aarti madam, that when I take two sutures, I suture them. Okay, I suture the ends of both the sutures. I think Kiran sir has also seen me doing that. The reason why I do that is, I think, okay, now because all of you have forced me, I'm doing those case report type things. Okay, I think I have seen the maximum number of open wounds post adenomyomectomy and post myomectomy for any person on earth. Okay, for any person on earth, and I would have repaired all of them. Okay, and all of them will require resection anastomosis of the small bowel, because it opens like a small, your myoma will open at one point. Bowel will go and get inside and get strangulated, and patient will complain of vomiting after 4 days, 3 days, 2 days, whatever. Understanding? Even if you do open myomectomy, even if you do closed myomectomy, whatever myomectomy you do, it will happen. Okay, and that bowel gets strangulated, patient presents with vomiting, she will require resection anastomosis with redo surgery of that completely gangrenous myoma bed. That myoma bed is gone. Understanding? Some people will require hysterectomy also in that situation. So don't abuse barb, yaar. It is too good. I mean, I really love it. Just use the correct barb. If you use, we'll have one session on how to use which barb at which place,
Yeah.
And if that will be a blast hit session, because everybody who thinks they know how to use barb are actually making one mistake, which I'll tell them, and they'll be like, "Haila, ye kabhi socha hi nahi tha," types, So we can have a session on that. But yeah, use barb on the fresh bowel injury. Nothing will happen. It's beautiful.
Right. Jay, just a couple of more questions. I know we are already 1 hour down, and time has passed so fast, and there's so much of learning more to do. My question is, say the surgery went off well, and you don't think you've injured the bowel, the patient is post-op. What are the telltale signs that maybe there was a bowel injury, and what are the tests you would want to do to diagnose and follow up?
See, the first thing which goes wrong in any bowel injury, okay, the first thing which happens in bowel injury is peritonitis. And the first thing which any peritonitis does is it causes tachycardia. Okay, so tachycardia after 24 hours, See, we can understand first 4 to 6 hours somebody is having tachycardia because of the pain and all these things. Actually, even now that doesn't happen. If you give tap block post laparoscopic surgery along the ports, okay, you will not have tachycardia. After 1 hour, tachycardia will go away. Okay, but let's assume you have not given tap block. You have done a routine surgery. Okay, after first 24 hours, if there is tachycardia, that means something is wrong in the peritoneum. Now, what is wrong in the peritoneum? It can either be fecal peritonitis, it can either be bowel injury, it can either be pus, it can either be remnant fibroid, it can be whatever, but something is wrong in the peritoneum. Okay. This guarding and rigidity, no, it will develop when there is generalized peritonitis. Okay, when that thing has just begun to leak and when there is just staining and walling off and all these things, no, there is no tenderness, no guarding, nothing is there in that situation. Tachycardia is the first thing which happens. Okay. The best test you can do, okay, in this situation, if you have the facility, kindly do a CT scan with contrast. Okay, that is the best thing to do. Do a CT scan with contrast. If you think it is a very low bowel injury, put a rectal contrast. No radiologist knows how to put rectal contrast. I'll teach. It's a very simple method. I'll post it on the groups. I have been putting rectal contrast for more than 500 scans now. For all our radiologists in our town, it's very easy to do, and a gynecologist can do it the best on earth, in my opinion. Okay. The second thing which you should understand in this situation is, even if you don't understand anything, and if there is tachycardia after 24 hours, kindly step up your antibiotics. Don't follow a strict protocol that I give only Augmentin. Okay. If there is persistent tachycardia, even till you evaluate, you must switch to Piptaz, Meropenem, whatever is your, whatever your microbiologist has suggested, but you must switch to that. Okay. What we normally do is, if there is persistent tachycardia, we will always call 3 people. Okay. After 24 hours, the first person whom we call is the anesthetist. Okay. He is going to come, he is going to put a central line. Okay. Putting in a central line is something which every gynecologist should know. I know it very nicely. Listen, nobody puts central line better than an IVF consultant. If you want the best central line on earth in the worst patient, catch hold of an IVF consultant and he will put it. The reason is because IVF consultants are used to picking up the stupid follicles from one corner of the ovary, understanding while doing IVF. So when we put Dopplers, no, our needle precision through the Doppler is superb. Superb is the word. Okay. So IVF consultants are the best people to put a central line. But chalo, if we have inferiority complex, no problem. Call anesthetist. He will put central line. First guy. Second guy, always call a physician. Rule out pulmonary embolism in all gynec cases and ensure that the physician is writing down on paper that it does not look to be pulmonary embolism. Many confusing signs will be there at this point in time, but a physician opinion on paper, medico-legal safety has to be documented that you called one more guy. Okay. Third thing, in this situation, take your ultrasound probe, put the ultrasound probe at the hepatorenal pouch. If the hepatorenal pouch is showing some collection, okay, you must, and that collection is going to be little turbid, you will come to know. You will come to know the difference between a blood collection. You will come to know difference between ascites, and you will come to know difference between a fecal peritonitis. It's very easy. I mean, I am not the world's best sonologist, but I know how to identify fecal peritonitis on ultrasound, understanding, and you will know. The minute you see that, no, then don't waste your time waiting for supine X-ray, sleeping X-ray, standing X-ray. All these things don't do. Put in a laparoscope, because remember, patient is in tachycardia. Getting fitness from your anesthetist to put a laparoscope in a tachycardic abdomen is not easy. Cardiovascular parameters are going to be challenged. That is why you should put central line before you do all this nonsense. Understanding? Which is why I said call the anesthetist first. Put the central line. Okay, put it. Even if you shift the patient on central line, the opposite person will not open his mouth against you. He'll be like, "Arey, isne kuch to kiya hai." You know, patient will be like, "Nahi, kuch to kiya hai. Dekho, na gale mein bhi dala hua hai." And this is really important from medico-legal safety. Then if there is tachycardia, if you're confident, put a laparoscope. Abdomen will be distended. So don't worry about it. It is a distended abdomen in whom you are putting a laparoscope. Understanding? You will see the wound. It's not so difficult to see the wound. But by the time your scope goes in, the wound would have become infected. Okay. On an infected wound, if you suture, it will break through in the next 24 hours. If it is a fresh wound, you can suture. If it is an infected wound, you have to divert. You have to divert, and you have no other option but to divert. Okay. So you have to divert. You must take consent for ileostomy, colostomy. See, I am not a very big fan of ileostomy. I'll justify it. Okay. Ileostomy, we do laparoscopically. It is the easiest thing to do. Correct? Why? Because ileum has mesentery. You don't have to do anything. Put a 10 mm trocar, bowel grasper, pull it out. Ileostomy is finished. Understanding? But ileostomy does not have formed stools. The ileum does not form stools. You will expose the patient to a much higher electrolyte imbalance if you have done ileostomy on your patient. If your ileostomy is a prolonged ileostomy, 2 months, 3 months, patient will have weight loss. You will have to treat the patient along with all these things. You will have to give parenteral nutrition, proteins, all these things to your patient if you have a prolonged ileostomy. Understanding? That is why it is better to do a transverse colostomy or a sigmoid colostomy. Understanding? Hartmann is basically an end colostomy. Why we do Hartmann? People say, "Arey, you do Hartmann, that is because you have to do pelvic exentration and all these things." No. In emergency situations, sigmoid forms the best tools. The water and electrolyte imbalance with sigmoid is the least, and sigmoid has a huge mesentery. So when you do a Hartmann, after 3 months, when you put a scope, that bowel injury from 1 centimeter would have become 1 millimeter. You can put local anesthesia in the bowel. Local anesthesia will leak out in the surgery, and you can suture it. Once you suture it, you can do redo correction of the Hartmann in the same sitting. Understanding? And that we have shown on Facebook. We have done so many of them that we have shown it on Facebook as well. Okay. But keep these points in mind. If there are take-home points, then I think these are important take-home points which come to my head at least,
Right. Such valuable lessons, Jay. Somebody who has really done a great number of such cases can share all this knowledge with all of us. Thank you so much.
Sorry. One more important thing. Don't shift the patient without a cardiac ambulance. This patient, if you are shifting from your hospital to an institute, it has to be in a cardiac ambulance. That is the most important thing. You cannot shift these patients on a routine ambulance. Put the patient in a cardiac ambulance and shift the patient in a cardiac ambulance, not in a routine ambulance.
Medico-legally, so you said talk to the patient, inform the patient, and call these 3 important people whenever you notice that there is a problem. And you said, of course, put in a central line and shift in a cardiac ambulance. Anything else medico-legally you think?
I'll tell you what is important. So let's assume I've handled 50 fecal peritonitis in the last 1 year. All right. None of them have done a court case against their referring doctor.
Great.
So it is our duty. At least I think it is my duty. If a patient has come to us now, these days, patients with peritonitis come to us directly. Because if the gynecologist is having an ego to shift, the surgeon will come and shift. No, I'll shift it to Jay's hospital. You do what you want. You sort out your ego issues later. First, let the patient live. Understanding? In this situation, I think what is so important is how the approaching doctor handles the relatives. Okay. In order to handle the relatives, normally, look, when the minute you are getting shifted from one hospital to big hospital, don't think patient is an idiot. The patient and the relatives know that there is a problem. They know that the patient will require some higher care, higher facility, higher surgical expertise, which is why they are shifting. Understanding? Otherwise, nobody likes to shift. Just like how nobody likes to abandon, nobody likes to shift as well. Okay. When this patient has been got to you, the most important thing is till all this workup is happening, it will take 1 hour, 2 hours sometime for all these things to happen, fitness to come, CRP would be done, but procalcitonin is missing. Procalcitonin is done, but 2D echo is missing. Sometimes these things are going to happen in our routine day-to-day situations, right? When these things happen, take the relatives in your cabin, tell the relatives that this is a common thing. Look, I'm handling this, once in a week, you need not worry. Prognosis is bad, but at this point in time, you need not worry. We all pray to God. Understanding? Second important point, after the surgery is finished, don't come out and tell the relative everything is okay. Please don't do that. Because when everything is okay, patient will die after 72 hours in fecal peritonitis. Okay, that endotoxinemia is so bad. Okay, even if you don't require anything, my humble opinion is to put the patient on NORAD support. Okay, put the patient on cardiac support. Trust my word on this. Okay, put the patient on NORAD dobutamine support in fecal peritonitis and then taper it off. But it should not happen that you had to start the support because the heart was sinking. Okay, you start that medium support before all these things happen in these patients, because it is very, very important. As a gynecologist, I think I'm an expert at giving NORAD drips and dobutamine drips. I'm super expert. But of course, if my opinion is not valid, call a physician, call a cardiologist. They will help you how to do these drips and do these drips. It is going to be prudent, even if you are shifting, to get it in writing from your cardiologist or physician if cardiac support is needed to this patient or not, because septicemia will also affect the heart very badly. Okay, so keep that in your mind. This, I don't know, I think probably these things are not given in many textbooks. These are things which you are going to learn on the job, and these are going to be things I am telling you. Don't go and tell the relatives everything is fine, because once upon a time I have done this to a relative and the patient died. And then those relatives have danced on my head. Are you said everything is fine. Are you said everything is fine. Are you said everything is fine. So till the patient is out of ICU and is in the ward for 2 days, don't say anything in these situations. Okay. And usually then once the patient goes home, it's a very, 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 very thankful, surgery. It is something which is very good that somebody has recovered out of this. Okay. So one point which people add, you give a thorough lavage. Even if you give a thorough lavage, endotoxinemia will persist because it has gone in the blood. Okay. So your thorough lavage is also not going to work. So keep that in mind.
These are eye-opening points of wisdom. Thank you so much, Jay. Any pearls of wisdom from Dr. Yogesh, Dr. Kiran?
I'm not regularly coming across the bowel injuries. So only once I had bowel injury, that too while putting this thing, needle holder inside with the needle, that went straight inside the colon. But luckily that was not much soil, so I can suture it. That was the only thing.
Right. So Jay, I think we can end our session today.
No, Kiran sir, I think wanted to ask something.
Yes.
What is it, Kiran sir? Acha, unmute. Yeah. I'll unmute you. Sorry, sir.
Yeah, Jay, we were supposed to take the questions.
Yeah.
We have on board Dr. Aarti Luthra. I think she's from Dehradun. Welcome, Dr.
Oh, she's a great surgeon
Yes.
from Dehradun.
Yes. Yeah. So Dr. Aarti's question is, what should be done if there is distension with lot of bilious discharge in rise tube on day 2?
Oh, so that is again a sign of peritonitis, no? Bilious distension, bilious discharge coming from the rise tube means even the sphincter between the stomach and the duodenum is not holding on, right? It is not able to push anything down. So if it is not able to push anything down, it is coming up. All right. So that means the patient has gone in complete paralytic ileus. You need to find out your electrolytes and, whatever thing. You need to investigate this very seriously.
Okay. Another question was, which number of Statafix do you use, 20 or 30?
Oh, it depends. But I normally like to use 20.
Okay. People would definitely like to see the tap block that you give post any laparoscopic surgery. Yeah? Any video?
Okay, we'll show it tomorrow. No problem.
Yeah. And
Kiran sir, I had given it in Pune on my own, yaar.
Yeah, I know that. A lot of people are asking these questions. Anyway.
No, it's easy to give. Once I teach, anesthetists will be out of work. Huh? All gynecs will be starting to give tap blocks on their own. It's so easy to give, yeah.
Achha, and another question that is posed is, does LAVH have more ureteric injuries than lap-assisted VH? Anyway, what is your go on lap-assisted VH, and will it have less ureteric injuries?
No, yaar. Come on. Ureteric injuries are going to happen because of traction, counter traction. Ureteric injuries don't happen if you do vaginal surgery or abdominal surgery. There are so great vaginal surgeons, you know, they've never had a ureteric injury in life, no? So they are dissecting correctly. That's why they've never had. And you have people who use, you know, harmonic for round ligament, and you have people who use ligashore for uterine, and they will still have ureteric injuries twice in a week.
Yeah.
So it is not based on this. Yeah, you should not see. You can't really talk about vaginal surgery in front of me because I'm trained by Piley sir. He is one of the best vaginal surgeons in the country. And by the way, I do very good vaginal surgery. Okay. So there is nothing that vaginal surgery is going to expose you to a higher risk of any injury. It is your surgical technique. Blame your technique, not the route of surgery.
Another question is, I think it is very simple. After pre-op or overnight exudate or PEG-LAC, should we give enema in the morning?
No, not needed.
Dr. Sucheta madam has a question. Dr. Jai, can you unmute her?
Yeah, I'll unmute madam. Hi, madam.
Hi.
Hi.
Very nice webinar. And thanks, Jai. We are really delighted the answers which you have given us to us. I have one question. If there's a damage, just a serosa, we are not gone beyond serosa, not damage the circular fibers. Still, we have to close that injury?
Not compulsory at all, madam. So I normally recommend to close a circular wound only if the wound is more than 1 centimeter.
But how
Just
you'll
take
come
one
to know
small.
your damage? How you'll come to know your damage the circular fibers?
You'll see, no? You'll see the circular fibers in front of you, no, madam?
Okay, that's all. And if you are not using barb sutures, the alternative will suggest the Vicryl or something else.
Silk.
Okay. Okay, thank you, Jai.
Thank you, ma'am.
I don't know. There is a message from 1+60. I don't know who is 1+60. The name is not written, but he or she wants to unmute for a recent case which required a ICCU. Who is 1+60?
Can't see him or her.
That's what I mean.
Can't see.
Can you,
Dr. Deshmukh.
Yeah, Dr. Deshmukh, can you put on the camera, switch on the camera so that it is possible to unmute? Yeah, yes, madam. Dr.
Oh, Meghashri madam. Hi, Meghashri madam.
Hi.
I've asked you to unmute. Hi, Kashya. Was it?
ठीक है तुम्ही फार बिझी आहात काही नाही just 4 days back I had a patient and sonographic findings were of pelvic cyst. We took her up. It was a post cystectomy cyst and they said ovaries, it might be left ovarian cyst. So I put a trocar. There were upper abdominal adhesions, they were removed, and then when I went into pelvic cavity, the cyst was not supposed to be seen. So we tried to release the adhesions from the ovary was released, but a cyst dikh raha nahi tha. So then I summoned the surgeon, surgeon. It was a sigmoid ke piche retroperineal. It was a cyst.
Diverticulum. Sigmoid diverticulum.
Acha. It was a cyst which we removed and the patient was okay. We separated the adhesions सब किया और फिर बाद में थोड़ा patient को बताया कि intestine का adherent था, यहाँ से निकला है, mesentery के पास में है, सब बताया. And 3 days she was okay. Third day, just 2 days prior, she took liquid diet, अनार juice सब लिया. रात में उसने pineapple juice लिया. Pineapple juice and 2:30 से मेरे को call आना चालू हो गए. She is vomiting profusely. एक बार vomiting हुआ, 3 बार loose motions हो गया. And 4th time now she had bilious vomiting. BP shoot up to 170.
ये सुनो ये sigmoid diverticulum injury हुआ है. Open करो मैडम. Open right now. Stop the Zoom meeting and go and open it right now.
Okay.
और diverting transverse colostomy ले लो. अभी का अभी.
क्या वो तो अभी ICCU में और sips of water ले रही है.
नहीं.
बंद हो गया बोले.
अरे नहीं. This at least put a laparoscope because you will miss out. वो walling off हो गया है. खाना खाने का चालू करेगी वापस चालू होएगा. It is got walled off क्योंकि diverticulum wall off हो जाता है पीछे. अच्छा.
तो any segmented diverticulum होगा वो.
हाँ, वो आप contrast डालोगे ना, it will show query spill करके दिखेगा. मतलब वो diverticulum में कुछ तो hole bill किधर तो गिरा है.
अच्छा, तो फिर मैं बोलती हूँ, बात करती हूँ ऑन्को सर्जन से.
हाँ
Today
हाँ
only they
बात
shifted
करो.
from ICU to next ward. चलेगा. That would be better.
बात कर लो एक बारी मैडम.
Okay. Any other investigation you would require?
नहीं, पल्स कितना है?
पल्स स्टेबल है, 86 है, टेम्परेचर नॉर्मल है, एम्बुलेटरी है पेशेंट.
एक सीटी स्कैन कॉन्ट्रास्ट कर लो मैडम. रेक्टल कॉन्ट्रास्ट, ओरल कॉन्ट्रास्ट दोनों मिला के.
रेक्टल और ओरल कॉन्ट्रास्ट दोनों.
दोनों दोनों दोनों.
ओके, चलेगा. चलेगा.
या.
थैंक यू.
Kiran sir, yeah, you wanted to be unmuted. Unmuting you.
No, are we still live?
Yeah, we are live.
Yeah.
No, madam was asking that question. That is. Okay.
We are
I
live.
think. The other questions are on, I guess, psychogeal fistulas and all. We will take fistulas and all in a different session, I think.
Yeah.
Right?
Yeah, we'll take fistulas in a different setting.
There is a relevant question. Any anesthesia technique to reduce bowel distension?
Spinal plus GA.
It's a good take home. And is there any role of a flatus tube here?
No. Flatus tube is to, if you have a distended rectum and you want to empty off that rectum, and if it is aparalytic, I mean, if it is in paralytic ileus, then. Otherwise, flatus tube डाल के क्या करेगा?
Anyway, I guess, yeah, we come to the conclusion of this session. I don't think there are any more questions pertaining to this topic.
Okay, so what we'll do is more questions we'll take on WhatsApp.